Hello, and thanks to everybody for joining us today for our program on employer-sponsored insurance. I am Marilyn Serafini, and I'm Executive Director of the Health Program here at the Bipartisan Policy Center. The majority of Americans, those under the age of 65, get health care benefits through their employer or through a family member's employer. That makes employer-sponsored insurance the nation's largest source of health coverage. Employer insurance is a popular benefit, but rising healthcare costs make it difficult for employers to maintain benefits. These rising costs constrain real wages, and they increase financial barriers to critical healthcare services for both employees and also their families. In response to these challenges, our health team here at BPC is today releasing a report on policy strategies to address underlying cost challenges and to empower employers. I'd like to thank the Robert Wood Johnson Foundation for its generous support of BPC, which has enabled us to take on this important issue. Before we turn to the panel, Sabah Bhatnagar, a senior policy analyst here at the Bipartisan Policy Center, is going to walk you through our key recommendations. Sabah has led our efforts on this report, so I'll turn it over to you, Sabah.
Thanks for that introduction, Marilyn. Good afternoon or good morning, depending on where you're watching this from. I want to take a couple of minutes to highlight this report and also introduce our incredible expert panel. I'd also like to thank my colleagues, Kendall Strong and Brady Newell, for all the work they put into this project and the report. Throughout the process, healthcare costs came up as the top concern for employers and employees. Employer healthcare costs have gone up 47% in the past decade. Rises in premiums and deductibles have outpaced inflation and wage growth in previous years prior to 2022. And we know employers and employees are feeling these increases every day. Many expect huge increases for 2023. But what's contributing to cost increases? Well, hospital costs made up 46% of plan sponsor healthcare spending in 2022, and pharmacy spending accounted for 23%. Furthermore, multiple studies show that healthcare prices are the largest contributor to healthcare cost growth, and hospital prices are a critical driver of this, having risen 42% between 2007 and 2014. Unfortunately, individual employers, even large employers with geographically dispersed staff, often have very little leverage to drive down healthcare prices. As such, we need policy solutions to strengthen the nation's ESI system and address cost drivers. Today, BPC has released a report to do exactly that. Our report recommends policy solutions to tackle cost drivers and strengthen ESI by increasing transparency in the healthcare system, empowering employers with payment and pricing tools needed to create a higher value ESI system, and addressing healthcare consolidation. Some of these recommendations include requiring HHS to establish a centralized data repository to host payer and provider pricing and quality data, because current transparency laws don't allow for apples to apples comparisons, and hospitals and payers are producing many times inconsistent, incomplete, or hard to navigate data. We'd also like there to be some sort of public tracking for healthcare ownership to really surface what impact private equity investment is having on healthcare prices, and whether or not it's leading to positive disruptions in healthcare delivery, leveraging existing Department of Labor authorities to boost accountability for stakeholders involved in managing and deploying health benefits, empowering federal agencies to most effectively use their resources to manage healthcare sector consolidation, prohibiting anti-competitive contract language such as anti-steering, anti-tiering, and all-or-nothing clauses in insurer contracts with providers, directing agencies to provide guidance on to encourage the uptake of high-performance networks, and also encouraging multi-payer coalitions so that payers can band together to pursue innovative approaches and improve outcomes and costs. To help us illuminate our report and other policies to improve ESI, we are joined by moderator Alan Weil, Editor-in-Chief at Health Affairs, and 3 experts who will share their perspectives on creating a higher value ESI system. With us today are Chris Whaley, a healthcare economist at RAND, His research focuses on healthcare price transparency and market structure. Notably, he's done a tremendous amount of research on the disparity between Medicare and commercial hospital prices. Katherine Gudiksen, executive editor of The Source on healthcare price and competition at UC Hastings College of Law. She focuses on policy solutions that promote competition and address high healthcare prices. And Elizabeth Mitchell, the president and CEO of Purchaser Business Group on Health. In her position, she uses her extensive experience in working with healthcare purchasers, providers, policymakers, and payers to improve healthcare quality and cost. We also encourage audience members to submit questions for our panelists. If you are tuning into this discussion, you can submit questions via YouTube by leaving a comment on this YouTube stream or via Twitter by using the hashtag BPCLive. So with that, I will turn it over to Alan. Thank you.
Thank you, Sabah, and thank you, Marilyn, for your leadership in this area. It's great to have a conversation about employer-sponsored health insurance. So much of the public policy discussion focuses on Medicare and Medicaid for very good reason. But as you noted, the majority, the larger number of people are covered by employer coverage, and we tend not to talk about it quite as much. In that context, I'm pleased to note that just this morning, Health Affairs released the annual, let me try to get that in front of a camera somewhere, our annual report from the Kaiser Family Foundation survey of private employers. It's quite an anomaly in 2022. Actually, employer premiums didn't go up very much. I think, as you heard from Sabah, the expectation, and others have said this, is that they'll go up quite a bit in 2023. So this is a bit of a backwards look. But there's a wealth of information about employer coverage here, and of course, trends over an extensive period. They've been conducting this survey for quite some time. We're pleased to publish it every year. With that, let's move into the conversation. I'm going to structure it around 3 of the 4 sections of the report, although we may bring in the 4th as well. But I think it's going to be easiest to follow if we have a conversation first focused on some of the transparency provisions, second looking at some of the market dynamics, and third looking at the role of employer and group purchasing. These are not distinct categories, but we're going to try to introduce the topics one at a time and work their way through them. So I'm going to start by turning to Chris Whaley, whose work has focused on transparency. And sitting as the editor-in-chief of Health Affairs, I have to say I've seen a fair number of papers on transparency. We all can appreciate it as a value, as a good thing, but it's pretty hard to find a lot of evidence to suggest that it's going to bring down prices. So maybe if you could just give us a bit of an introduction to the role transparency can play in controlling prices for employer-sponsored insurance, and to the extent you feel comfortable, maybe reflecting on a little bit of what's in the report about how it will respond to the barriers to achieving the potential that transparency has. Chris?
Great. Well, thank you, Alan, for the introduction, and really excited to be presenting to this group. The way, first I look at the employer-sponsored market and the potential role of price transparency in this market is that employers, as was noted earlier, provide insurance for over half the country. And it's important to recognize that those costs come out of worker wages and benefits. And then a third point is that there's just a tremendous amount of dysfunction in employer-sponsored and private insurance markets. One just kind of very notable source of dysfunction is that there's no, or very little rather, price transparency or information on prices. And so we have a dysfunctional market that's tremendously huge and important, and a lot of that dysfunction really eats into worker paychecks and other types of benefits. And so if we think about kind of the scope of the employer-sponsored market, not just the over 160 million people that receive insurance in this market, but the over $1 trillion that's spent by employers and by workers on healthcare, this market, is noted earlier, just has no information or very little information on prices. And so a few kind of innovators over the last 10 years or so have really decided that this is a important problem to tackle, and one way to improve information on prices in this market is actually to give information to consumers and to patients, and really let them kind of be the smart shopper for healthcare. And as Alan noted, there have been a bunch of studies, including several in health affairs, that have shown that this model doesn't actually really work that well. And so maybe that's not surprising if you're a patient and you're consuming care. This is one of the most challenging times in your life in many cases. And so the idea that you're going to kind of now decide to think about dollars and cents maybe doesn't make a lot of sense to how patients actually navigate these types of situations. But then the other way is to just kind of think about what's the process through which a patient will actually use price information. So if you're a patient and your doctor says, look, I want you to go get a surgery at this provider or a MRI at a given provider, the kind of price transparency, consumer focused price transparency ideas that you as a patient are going to use your price transparency tool and go in and say, look, doctor, you're actually wrong, and I should actually go to a different provider than you were telling me to go to. And it's not, I think, very realistic to expect that many patients will have those types of conversations with their providers and their physicians, and for many good reasons. And so there's been kind of maybe a bit of a push to say, well, price transparency doesn't work, and patients aren't using these tools, and so maybe we should just throw our hands up. But I actually think that's not quite the right approach that we need for the healthcare system and for this market. I think it's important to recognize that there is lots of value in having information about prices, but it's really a question of who uses that information. And so the idea that patients are going to be able to use transparency to navigate the healthcare system, which is already incredibly complex, hasn't really borne out so well. But I think that a potential way that price transparency can be used is not necessarily as kind of a patient-focused tool, but more as a hub that enables lots of the other benefit design, regulatory, and other decisions that are upstream from patients. And so we know that there's a tremendous amount of variation in prices and low-quality providers that are charging higher prices. And so maybe a potential role of transparency is actually not to put the burden on the patient to navigate the system, but actually to address many of these underlying issues and systemic issues in the healthcare system, and make sure that if networks are designed, they're designed to favor high quality and lower price and efficient providers. Regulatory decisions can use transparency to make sure that markets that are not competitive or face little competition don't charge higher than we would expect prices. And so I think that's kind of at least the potential role of how transparency can be used is again more kind of the hub that enables lots of these other types of innovations rather than an end-all solution by itself.
Frame, and I'd like to bring in our other panelists to focus on this topic a little bit. Elizabeth, maybe I'll turn to you next. I know we'll talk more about opportunities for employers in general, but from where you sit, do you feel like a lack of pricing information is a key barrier to employers making better decisions?
Absolutely. Imagine an employer procuring anything else for their company, whether it's tires for an airplane. They wouldn't do it without any visibility into the price and the ability to sort of compare prices. So it's, transparency is absolutely necessary and yet absolutely insufficient. So it is the precondition for a competitive market because, purchasers who are, my members alone, and, we have about 40 jumbo self-insured public and private purchasers. We are purchaser only, which is very important to sort of avoid the conflicts that often hamstring some of the multi-stakeholder groups. But they spend about $350 billion a year purchasing healthcare for their employees. They are very invested in a high value system, and yet they can't even get visibility into some of these prices. So it is a precondition for a competitive market. There is absolutely a reason hospitals and health plans have fought transparency for so long, because it gives them an enormous advantage. And yet, to the point you heard earlier, it's not enough to have the information available. It has to be usable by the actors who can actually make a difference. I completely concur. It is not fair to expect a patient to change the healthcare system. They have zero leverage. A $10 copay or shifting a procedure, that is not adequate to actually change the market. You need the information to be available to those who are truly purchasing care at scale, and they will use it when it's available. And I actually think there are significant examples of where it has worked. There are examples, I've actually been part of them, where when a collective of employers have transparent information on cost and quality and they steer patients to those higher value providers, that makes a significant difference. Or reference pricing was very impactful. All of those presume transparent information. So we are wholeheartedly supportive of making that information more available and more usable. And then we can enable our purchaser members and others to actually leverage it to change the system.
Thank you. And again, we'll come back a little bit more to what some of those lever opportunities are. Katie, again, we're going to focus a little bit more on market dynamics in a moment, but when you think about an effective market, when you take Econ 101, full information is a core component of that. Do you have a sense of the degree to which the absence of good information is a factor in poorly functioning markets? And would you agree with Elizabeth's comment that the hoarding of information is sort of seen as a competitive advantage and therefore something that you have to force actors to change their behavior because they won't do it of their own accord as long as they don't have to?
Yeah, thanks, Ellen. I absolutely agree with Elizabeth that the hoarding of information or obscuring of prices, et cetera, it can be a competitive advantage. And I would go even beyond Elizabeth and say that many policymakers and especially at the state level, a lot of the prices and consolidation is also hidden from them. And when they're looking at other, the types of policy solutions that we'll talk about in a few minutes and sort of market oversight, the lack of transparency, the lack of knowing exactly where to focus efforts can really hamper efforts by policymakers to target specific policies to address specific inefficiencies in the market or places where there has been exceptionally high consolidation and therefore exceptionally high prices.
So I have a question that I'll toss out to all three of you for whoever might want to consider it. One of the recommendations in the report has to do with a national effort to create all payer claims databases. About half the states have them at this point already. When I think about those databases, of course, they're backwards looking, they're claims, and we publish a lot of papers on proprietary databases that include a lot of claims. Medicare, of course, also has claims data. Medicaid's a little harder to get to. I'm just curious from any of your perspectives, whether the all payer claims data approach sounds like an important tool, and whether there are any dimensions of what those need to look like that you think would make them more useful rather than less.
Well, I can start. I actually assembled and ran an APCD, All Payer Claims Database, years ago, and there is enormous potential for that data. And I will say the biggest potential is around cost and utilization data. It's less valuable for quality data, but there are other sources for that. And I want to actually acknowledge Robert Wood Johnson Foundation. They allowed us to do a multi-state study creating comparable total cost and resource use information across states that was highly valuable. So we know it's doable. It's doable with existing, APCDs, and it could be scalable as a key way to look at what is happening with prices, or utilization or cost overall. I think that having that data available nationally would have enormous value. But what is the secret to making these work is actually the governance, because there are also plenty of APCDs out there who are too controlled by plans or others who have interest in the data not being made available. So getting the governance right is essential to really leveraging them.
Goes back to this issue of it's not a voluntary action, at least in the first instance. Chris, it looks like you wanted to weigh in.
Yeah, so I would just echo the governance point. There are some states that have invested a tremendous amount of resources and building and collecting data for an APCD, but then somehow along the way provisions have been put in place that the APCD data cannot be used to display or disclose any information on provider specific prices. And so from my sense, that really just kind of defeats the whole purpose of an APCD. And when I look toward, think about kind of what's the potential of a APCD and how at least kind of states have used this or use these data, I really think a good example comes from the state of Colorado, which has, again, invested a tremendous amount of resources and energy into collecting and maintaining a APCD, but then also making it available for both researchers outside of Colorado, but then also Colorado employers and policymakers. And so over the last several years, it's been really great to just kind of see how this data has been used to inform decisions throughout the state. And so there have been several early employers, kind of innovative employers like the Peak Health Alliance, the Colorado Business Group on Health, and others that have used this type of data to actually go out and say, look, we're providing health insurance for our workers as a benefit, and we want to make sure that these prices align with the value that our workers are getting. And the Colorado APCD allows us to have some insight into those prices. The state of Colorado has also used their APCD data to inform a lot of the regulatory and kind of purchasing decisions. And so this includes both the role of the state of Colorado as providing health insurance benefits towards its workforce, but then also as a regulator and thinking about how do we provide health insurance to lower income Coloradans? How do we make sure that healthcare markets are fair and efficient? And so that's just been a really good example from a single state. And so when I think about a federal APCD, I think about just what would happen if we could do this across the country and not just kind of have the slice of state regulated plans, but also all of the ERISA members and plans within the data. And so I think that if we're going to have a honest conversation about prices, market structure, and the role of insurance and private insurance in providing healthcare, an APCD is just a critical step that we need to have.
It's nice to hear you voice Colorado as a good model. 30 years ago when I was there, we have a sunset provision in Colorado where a statute has to be re-upped every so often or it expires. And the hospital, this was long before anyone used the term APCD, but the hospital database was up for sunset and we weren't able to get it renewed due to opposition from the hospital association. So that was 30 years ago. It's nice to know some things have changed. I want to bring in our second topic here, which has to do with market dynamics. And again, these are all related, but I do want to make sure that we're giving each its due. A good portion of the report focuses on consolidation and efforts to reduce levels of consolidation. There's some provisions that are recommended with respect to pricing in markets that are more concentrated, particularly hospitals. Katie, I want to start with you with, again, sort of a fairly broad question. We've published plenty in Health Affairs that indicates that the general finding that I think is repeated by many, which is that there's basically no evidence in consolidation improves care, and there's significant evidence that it increases prices. So that gives you a pretty negative general take on it. But I'm also struck by maybe are we a little late to the party here? I mean, the number of markets where systems are consolidating, there's consolidation across markets, there's vertical integration has been so significant. This seems like a great topic from 15 years ago. So my question to you from where you sit now is there still a viable competition agenda, or are we too late to the party?
I think there's sort of two answers to your question, Alan. And I think absolutely, in many cases, you can pick your favorite analogy. The horse has left the barn, the train has left the station, et cetera. So we need to be thinking about another category of what— You don't like my party
metaphor?
Sure. But I think it is time for policymakers to start thinking about how to address prices directly, looking at contract terms, prohibiting the ones that are used pretty much exclusively anti-competitively, et cetera. But I do want to make the case that there is still room for some market oversight. There's some interesting, pretty innovative program that started in Oregon. There's one that's, the one in California is just sort of up and running and looking at sort of the smaller acquisitions or acquisitions by non-traditional entities. I think that's really important for states to do. And I think we're also seeing sort of health systems started out small and they sort of did horizontal and vertical acquisitions and mergers, and then they kind of expanded regionally. And now I think we're looking at really health systems expanding, nationwide, and sort of these cross-market mergers that are allowing them to expand their market dominance sort of in one market across the country. And really, we're just talking about these giant health systems now. So I would make the case that we actually need both. We need better antitrust enforcement to looking at these mergers, both at the federal level, these large cross-market mergers. I think we need to better evaluate small mergers at the state level, because sometimes even the acquisition of, say, one orthopedist, or pick your favorite specialty, if those start to get consolidated and tied in with health systems, that can really drive up prices. And then I think we also need to look at a number of options, some of which were addressed in the report, sort of thinking about other ways to promote competition at the insurer level, perhaps through a public option, or things like revisions to certificate of need laws that sometimes prevent market entry. I think the problem is so big and we've gotten so far down the road that we really need a number of policy solutions, both to protect the competition we have, to promote market entry, and then to prevent the abuse of market power, where it's clear that just dominant systems are driving up prices.
So it sounds like there really is a significant agenda in your mind that remains, and that's encouraging, that we're not, that the horse is, even if it's out of the barn, that we can maybe jump on it as it's running and guide its direction. I'm interested, of course, in comments from the others, two of you. I'm also interested in, I noticed, Elizabeth, that when you first introduced yourself, you mentioned that you're a buyer-only coalition. And I'm sitting here thinking about the politics of consolidation and the notion of leaving it to the states or to any regulatory agency that potentially we study the concept of regulatory capture. Where is this really as a priority? Is there a constituency for tighter enforcement when there are so many forces aligned to push for consolidation? It's a broad question, but I'd be interested in anyone's take on it.
Well, I would say we are certainly very interested in taking on consolidation. And, we have done it in the past. You may be familiar with the Sutter case. Sutter is certainly not alone in their practices. And the settlement that was achieved after 10 years, so I hope we can accelerate, but, $400 million is going back to employers, public purchasers, and their employees. So, and that was just the agreed upon amount. So that is not an insignificant win, but even more important is the injunctive relief that is coming from the settlement, where there are sort of new rules of the road, as it were, that will be enforced for a decade, that prohibit things like gag clauses, that require transparency of cost and quality, that prohibit, all or nothing contracting. Those things will enable purchasers to be more effective at buying the best care. We actually have a bill that we are behind and strongly supporting. Is co-sponsored, bipartisan co-sponsors, Braun and Baldwin, to actually create those same provisions federally. So we believe that will have an even bigger financial and sort of quality impact than the settlement dollars, because it will enable a competitive market. So I agree. Unfortunately, I think a lot of AGs were kind of asleep at the wheel. All of these hospitals have gotten together. There is no indication that quality goes up, even though that's, all the selling points. We're going to have better coordinated care. That is not what is happening. Experience for patients is worse, access is worse, and costs are much higher. So we've got to do more. And, this Baldwin bill may actually start laying the groundwork. So we'd be very, very supportive moving forward.
So that's a really, my first reaction is that the fact that we can count pretty quickly the number of high profile cases makes me worry about whether we'll ever catch up. But I really appreciate the point that the settlement provisions are not just about money, they're about practices. And if you look at the BPC report, a lot of it is about practices. Katie, you mentioned some of them as well, that even even in a consolidated, not fully, monopolistic market, but in a consolidated market, if you can eliminate some of those most anti-competitive practices, you could potentially create some room for negotiation, and that doesn't exist, not just because there are only a few players. Chris, do you have thoughts on this topic?
Yeah. So one of the things that we learned when we were doing our prep this morning is that the three of us panelists actually live probably within 10 miles of each other in the Oakland, California area, where in this market, which is probably 1 million or so people, there are essentially two hospital systems. So the Sutter system, which is mentioned earlier, and Kaiser, which has lots of restrictions in access. And this is really the result of decades of consolidation in this market that has led to incredibly high prices and actually worse access to care given the population size. And this dynamic has been replicated in many other markets across the United States. And so at least what I would worry about is that in these types of markets, the reality of undoing these decades of consolidation and saying we're going to break up some of these ginormous hospital systems really isn't that realistic. And so in these types of markets, if we are going to recognize that the provider systems are so entrenched, maybe we do need to think about what are the policy options or the pricing options to make sure that patients and consumers don't feel these adverse consequences of this consolidation that has really gone on over the last several decades.
We received a question from the audience I want to bring in. I think it's a very useful question to ask, which is, are there different strategies with respect to horizontal and vertical consolidation? And those terms probably roll off the tongues of all of us, but maybe Katie, I'll ask you to start just with a quick definition of the two and maybe take a first cut at the answer on strategies to respond to them.
Sure. Well, when we talk about horizontal consolidation, we're really referring to two competitors in a market that are coming together and merging. So the obvious example is two hospitals that would compete for patients, or a patient could choose between those two hospitals in the market, those two hospitals coming together and forming one system. When we talk about vertical consolidation across industries, that's just two different players at two different levels in the delivery chain consolidating. So in healthcare, the obvious example is hospital systems buying up physicians. It could also be clinics, et cetera. I would say in our work, and then I also use the term cross-market merger. So I want to make sure that I define that too. And that's where a hospital, say in two different geographic markets, so a hospital in LA and a hospital in San Francisco would get together and form one system. And there's some market power that can be gained from that. And then also say a specialty clinic merging with a hospital, et cetera, that could be considered a cross-market merger as well. And I would say that sort of the antitrust laws, the state and federal antitrust laws, prohibit any mergers that would substantially lessen competition. So we don't necessarily need to break down into these categories for antitrust law, but the FTC and DOJ have horizontal and vertical merger guidelines that are being rewritten right now, but they do tend to review mergers with a different lens when looking at those two kinds of mergers. So in terms of different strategies, I guess in terms of the antitrust strategy, if a lawyer or the AG or the federal antitrust enforcers are trying to go to court to block a merger, there would be slightly different cases. In terms of sort of a market oversight program that we could talk about the Health Policy Commission in Massachusetts, or again, Oregon or California. I think those states are beginning to take a more comprehensive view of mergers and sort of looking at how a particular merger affects the market power of that system. And I think that's likely to be a more effective way of looking at market power rather than sort of putting things in a horizontal box or a vertical box or a cross-market box.
That's really interesting. I'd love to spend more time on this. I'm not sure. Not sure we will do it here. I want to. Oh, yes, go ahead, Elizabeth.
Sorry, I just got to get, because this is really a problem for purchasers. And I want to just mention the vertical consolidation, just calling it out. You have the health plans who are now owning the PBMs, who are also owning the practices. And it's essentially creating it's impenetrable when you're trying to negotiate, even with the largest purchasers in the world. That vertical consolidation is making it incredibly difficult to identify quality, get price transparency. So The horizontal consolidation is also problematic, but they are buying up these entities to control referrals, to control prices. It really needs attention. So I just want to underscore that.
Well, I appreciate that. And I'm sorry, Chris. Yes.
Yeah, well, it just, one other thing to note, I mean, so there's been a tremendous amount of work in health affairs, including just documenting just this huge trend of vertical consolidation with physician practices. But I think that one thing we should keep in mind is that in some sense what all this literature documents is that physicians are in some sense voting with their feet, that they either don't want to or given kind of current practice environments can't sustain being independent physicians. And so I think we're talking about the regulatory view of kind of how can we prevent vertical integration, or how should we think about the regulatory environment on vertical integration. We also, if we're going to kind of focus on that, need to put corresponding attention on what are the kind of practice environment or other policy levers that we can do to make sure that independent physicians can stay independent.
I appreciate you bringing that up. We treat this as sort of a market failure, but there is another market over there, which is physicians, the example you give here, choosing to sell their practices. And there's a portion of the report that discusses the role of private equity, and they wouldn't have a role if there were no sellers. So I think it's an important dimension that we often don't pay as much attention to. So I want to make sure we get into the role of employers, but I want one last question focused here on the consolidation side, which is, so given comments that I heard from each of you about limited likelihood or political will to unravel what's already been done, even as we might have some tools to mitigate the price effects of them. Where does that leave us in the markets that are highly consolidated? Maybe part of where it leaves us is some of the provisions, like in the Sutter case, around information transparency. But what about prices per se? Is there anything we can do directly on prices? Anything we should do directly on prices when it comes to highly consolidated, concentrated markets?
I'll jump in there, because
Please.
I feel like when I'm often giving these talks, the options are consolidation or price caps. And I don't think that there's necessarily that dichotomy. I think there's a number of states tried it back in the 80s and 90s, tried to do price setting, and we've, all of them except Maryland have moved on. But I think that there are a lot of policies. For example, Rhode Island has affordability standards where insurance premiums can only go up by a certain amount each year. And then the insurance commissioner, actually the health insurance commissioner in Rhode Island, can actually look into the contracts and look at price increases to individual providers that are causing those price increases. I think that there have been things like things proposed like capping out-of-network rates. So that was, if we go back to the Sutter case, that was another thing that was alleged in the Sutter case, that Sutter used really extreme out-of-network prices to really force employers to negotiate with them at higher in-network rates. There's good evidence that Medicare Advantage has used this sort of a de facto out-of-network cap to keep prices down. And then the state would only be, or state or federal government would only be regulating out-of-network rates. And we could still let the market work to negotiate within those rates. We also had a forefront article in Health Affairs talking about maybe taxing excessive provider rates. So provider rates above a given percentage of Medicare might be subject to an excise tax at the state. I think there's a lot of levers that really have yet to be tried that fall a little short of price caps that have all this sort of regulatory issues and regulatory capture issues that you brought up, Alan. I think there's a lot of options for policymakers to try to really to get at addressing prices, but there aren't exactly price caps.
That's very helpful. And I hesitate to move off of this topic, but I do want to make sure we have some time to talk about the section of the BPC report that focuses on employers. And the section's entitled Empowering Employers. And Elizabeth, I know you could have anticipated this, so I'm just going to dive right in. it's hard for me to think of your members as needing empowerment. They're some of the most powerful companies in the world. And we publish paper after paper in Health Affairs of all sorts of potential innovative strategies, reference pricing, value networks. And we've been doing this for decades, and it seems like somehow whatever it is we're adding up together isn't solving the problem. So I guess my question to you is, what tools do employers, purchasers need that they don't have, and why do they need someone else's help when they're already such, they have ERISA protection, and they have, huge, as you mentioned, huge levels of payment that they're making for these services. And one would think that if anyone has the leverage, they do.
Well, I love this question, and I get it a lot. So I have a few key points. First of all, as we've already talked about, even our members, as large and powerful as they are, don't always have the information they need in terms of transparent price and quality information. There has been historically a tendency to rely on intermediaries to do this on their behalf. I mean, when you think about it, healthcare is not their day job. They build computers or airplanes or sell groceries, and they are being sort of tasked with fixing the US healthcare system. As the market has gotten that much more consolidated, impenetrable, unresponsive, that job just gets harder. And frankly, the health plans and brokers and consultants and PBMs, they're all doing very well in the current system, thank you very much. So they have not had the same incentives as self-insured employers to actually reduce costs or improve quality. So there is a growing recognition, particularly after the passage of the Consolidated Appropriations Act of 2021, these self-insured employers are now fiduciaries. They are now obligated. They had the financial incentive before, but now they have a little more legal push to actually ensure the money they are spending on healthcare for their employees is based on fair prices, good quality, good value. They want, and they are putting enormous effort into buying care and services and support that enables their employees to be happy, healthy, to promote well-being. That is in everybody's interest. They have been really hamstrung by the system and the intermediaries from really achieving that. There is a myth that these health plans are particularly responsive, even to very large purchasers. It can take months to get data. It can take, multiple employers have to ask for something to make it happen. So there is a growing readiness among my members to basically go direct. About 20% of our members are doing direct contracts now. They find that when they work directly with the providers, their interests are entirely aligned or more aligned. And there is a growing recognition that what they've been doing has not had the impact one would hope. So with greater data and transparency, with greater tools, there is a real push right now to really just insist on the value, on the accountability, and to really think differently about how they are purchasing healthcare. So I actually think it's a very exciting time. We've done a lot of work. We're very focused on primary care, on mental health, on maternal health. I mean, maternal health and equity in this country is just, it's a disaster. I mean, we have rates of death and disparities that are just unacceptable. And so they are taking that on. How can they do something differently? We have members who are literally hiring doulas for underserved regions. And we have others who are, funding birth centers. They are taking a much more interventionist role in changing healthcare because the current system just has been unresponsive. So I think it's exciting, but there's a lot of work to do.
Well, that's really helpful. And I'm eager to see how we can learn some new models, and then other employers and other purchasers can learn from those who have the opportunity to do that. Chris, I am curious, at the very beginning, when we talked about transparency, you mentioned sort of the lackluster performance of consumer-directed transparency, but that there is value in the transparency going to larger enterprises that can make more sophisticated decisions. And you also mentioned the steering of individual patients with financial incentives. Do you see a potential positive role here with new tools and new expectations for employers combined with some of these transparency provisions to to yield progress on prices?
I do, and I think the Consolidation Appropriations Act provisions that actually require employers to care about prices and to care about prices that are being negotiated on their behalf and paid for by their workers actually will move this forward. And just a story that really, I think, dovetails what Elizabeth was saying is that we've done some work with the employer group in the state of Indiana who faced this problem where their healthcare costs went up every year, and at the same time, all their brokers, benefits consultants, and insurance companies who are carriers said, we're doing the best we can, and you're having really good rates, but they really had no insight into what was going on under the hood. And so we were able to collect their data and actually kind of reprice things for hospital care and look at how much each employer was paying at hospitals relative to Medicare prices for hospital care. And one of the things that really stood out is that a particular provider system or healthcare system in Fort Wayne, Indiana, we found was actually had some of the highest prices in the entire country. And so the employers who kind of were being told, everything is good, we're doing the best we can, actually had some insight into the prices that were being negotiated on their behalf, and took this data back to their carrier and said, look, why are you out there negotiating what are probably the worst prices for healthcare in the entire world? And we are paying you the privilege for doing so. And now that we actually know what's going on and have some insight and are able to audit the prices that you're negotiating, we want to make sure that you're actually out there negotiating better prices, or we're going to think about other benefit design or carrier decisions. And so this process actually both led to a new contract with the large health system and the TPA in this market, but then also led to other employers and other insurance carriers in this market deciding, look, we now need to think about prices, and we kind of have an eye over our shoulder when we're negotiating contracts. And the employers who actually have insight into these prices are going to be the ones that say that price is too high or too low, and in prices where they're not getting value from those prices are going to think about other options. And so instead of a kind of competitive advantage to not having any disclosure on prices, actually being transparent and competing on prices in this type of environment has been a kind of a new business strategy for many of these carriers. And so I think those are the types of examples where now that there's going to increase focus and attention on prices and transparency in prices, where maybe we'll actually see some benefits of transparency rather than just being a tool for patients to navigate.
Well, that's a great segue into the question I had in mind for Katie, because again, you presented a picture where you feel like there is still work that can be done around market functioning, even given the level of consolidation that's occurred. You combine that with transparency, and I guess my question is, do you see enough evidence out there of competitive markets that activated employers with large blocks of business in combination with the fiduciary role and the information really could make a difference in this?
I think possibly. I think they're still going to need support in terms of policies, in terms of prohibitions. Chris talked about sort of steering patients, insurers being able to steer patients to the highest value care. And if health systems are allowed to use, any steering provisions that we saw that were part of the injunctive relief in Sutter, and then also in a previous case in North Carolina, if health systems are still allowed to use these contracting practices, then insurers and employers, their hands can be essentially tied by these large health systems. So I think that's just one example where large employers and insurers really need the help of policymakers to prohibit these kinds of specific contract terms. I think that there are some markets, dialysis clinics come to mind as sort of obvious examples where it's just clear that there is very little competition left, and we need some of these policy solutions around the edges. I think in some markets there is still competition and there is still hope that markets could still function. And I think that we're the United States, we often want competition in markets to work, and I still think there are places where that is true. I just think that we need to put in some guardrails or backstops for policy to make sure that those markets are really functioning as efficiently as they can to protect patients and employers.
Well, it's perilous to throw out this topic when we just have a couple of minutes left, but I do note that we've talked a lot about competition and prices, and we focused on hospitals and physicians. The other large segment is pharmaceuticals, and there are a modest number of recommendations in the report. There have been many other people who've worked on this topic, but I wonder if literally in a minute or two, any one of you want to say something about the market side. We don't have to take on pharmacy pricing writ large, but given the themes of transparency and market functioning, are there comments particularly relevant to pharmaceuticals that are different, which are priced and operate very differently than hospital and physician services?
One thing I would say, and I'll try to be brief, is that PBMs are a huge contributor to the problem of drug costs. Yes, we have sort of, the cost of the drugs themselves, and we're having these, $1 million medications that are coming out. Those are all problematic and need attention. We're going to need to look at launch prices. We're going to need to look at, patent length and patent, evergreening, all of those things. But PBMs have largely gone sort of under the radar of policymakers and regulators, and they absolutely need attention. They are supposed to be acting in the interests of purchasers to manage costs. We know that that is not happening. So I just think there's a big opportunity to look at PBMs when we are thinking about anti-competitive practices.
Well, you kept that very brief. Any other, I think I have time for one more comment on pharmaceuticals, if anyone wants to make it.
I mean, I would just say, you think that like healthcare and physician pricing is complex. Wait till you see the complex and doesn't have transparency. Wait till you go to drug markets. I think there is, in addition to the previous points, one area where there should also be attention and where the two actually come together. In many cases, a patient, especially for a lot of these new oncology or rheumatoid arthritis and kind of specialty or injectable drugs, get care. They, don't just go to the pharmacy and get these medications. They actually go to a hospital or physician. And actually, in a health affairs paper, we highlighted that a lot of the same kind of price variation and price markup that we see for other medical services happen for these types of services. And so it's important to recognize that it's not just kind of pricing doesn't just stop at the PBM or the drug company, but actually in many cases goes throughout the healthcare system.
Great. Well, yes.
Can I add one thing? So we were very supportive of the new provisions allowing negotiation. I want you to think about, you want a competitive market and yet negotiation was prohibited. I mean, that's just crazy. So with the IRA, there will be negotiation of some prices for Medicare. We think that's a good start. I think that we should find a way to include commercial purchasers in that. So that would be on my wish list too.
Great. Thank you. Well, we are coming up to the end of our hour. This has really been, I've learned a ton from all of you and enjoyed it as well. And that's a great combination for me. I hope for our audience as well. It's hard to summarize this, but I think I'll just go through each of you one by one and ask if you have a few sort of summative thoughts, and I will ask you to keep them quite brief so I can finish up on time. But Chris, how do you put this all together?
So healthcare has been famously said is complicated, but we're at a point where we're starting to get new data and insights, and I think many of these data and transparency insights will continue to grow, and it is important that both on the employer side and the regulatory side that we actually use this data to inform decisions.
Wow, that was great. Okay, Katie, over to you.
Yeah, I think as we get more data, as we get more information about the functioning of healthcare markets, I think that there's also a lot of options that policymakers have. And when I think about it from a policy lens, I worry most about sort of indecision paralysis or sort of not knowing what to do. And my strong encouragement would be to try a few things around the edges for policymakers and then to see what's working, because it's not going to be it's not going to be a silver bullet. We're going to need lots and lots of different policies. The dysfunction has reached levels where it's just going to require lots of interventions by employers, by policymakers at all kinds of levels, and antitrust enforcers. And I think it's time to get to work on finding multiple solutions that are work together.
Excellent. That's so helpful. Thank you. And Elizabeth.
Yeah, I actually, as I said, I think this is a very exciting time. So large employers, public purchasers and families are the ones with the incentives to change the U.S. healthcare system. They're bearing the cost, and they are experiencing the dysfunctions. And, there's this sort of combination of outrageous pricing. And we know that for 2023, we're going to see another big jump, lack of responsiveness from very consolidated market players, and employers who have essentially turned some of this over to their intermediaries in the past are now taking it upon themselves to actually intervene on behalf of their employees or on behalf of their beneficiaries in public programs. And so there is a readiness to do things that haven't been done before, to go after quality and cost and access and equity, that I believe is going to lead to significant change over time. So the environment has changed. Sort of the regulatory environment has changed, also creating this fiduciary obligation. As more data becomes available, I think we're poised to see big and positive changes.
Well, Chris, Katie, Elizabeth, thank you for ending us on an optimistic note. It's and obviously heartfelt. I really like that. And now I'm pleased to hand it back over to Marilyn Serafini to close us out today.
Great. Thanks so much, Alan. Listen, to Katie's point, we agree. It is time to get to work. And that's why BPC is releasing this report today in the spirit of bipartisanship. We do have solutions in there. And you can see our report on our website, simplebipartisanpolicy.org. Thank you to Alan for helping us to navigate this complex but super important topic today. And thank you also to Chris, Katie, and Elizabeth for sharing your expertise with us. And thanks to all of you who tuned in. Look, we agree. This is a topic that needs some attention. And you can read our report, but let's keep talking. From the Bipartisan Policy Center, thank you very much for joining us today, and we'll see you next time.